Greetings to our valued AACP members. We are delighted to have you here. Today we have the pleasure of hosting Dr. Germán Ramirez Yanez and Dr. Carlos Vice. The format for today will consist of an introduction from Dr. Vice, followed by the feature presentation by Dr. Ramirez Yanez, and concluded with a Q&A session. Throughout the presentation, you will be seeing questions pop up on the right of the screen. In order to receive CE credits, you must answer these in a timely manner. If you have any questions, please post them to the right in the chat section, and they'll be answered at the appropriate time. Next, I would like to introduce today's moderator, Dr. Vice. He is the chair of the Education Committee for the AACP and a diplomat of the American Board of Craniofacial Pain. He also has a practice in Dallas that concentrates in cranio and orofacial pain, sleep, and orthopedic. Sir?
Thank you, Jordan. Welcome once again to another webinar of the AACP. For those of you that are not back in your office to at least a partial schedule, we have for you today a very special webinar. Those of you that have not heard Dr. Ramirez speak before, get ready for a very special treat. And those of you that have heard him speak before, get ready to definitely learn something new today. We're going to encourage you guys to go to our YouTube channel and sign up for any of our future webinars. Subscribe. That way, when you sign up, you'll be able to get updated with the new webinars that are uploaded to our channel. On May 19th, we're going to have Dr. David McIntosh from Australia speaking. He's an ENT. He's a pediatric ENT that has some fascinating information about treating kids with airway problems. He has a unique knowledge of dental, of dentistry and craniofacial pain. So don't forget to mark this on your calendars for the next time we have this webinar on May 19th. Today's also there's more learning opportunities with this weekly webinars, and we are try to post you every time. If you do click on the bell of the YouTube channel, you will be updated with all this information. Today's speaker is a longtime friend of our academy, has spoken numerous times to many of our members, including past annual symposiums. Dr. Germán Ramirez Yanez has a very interesting and extensive educational journey. He graduated from Javeriana University in Colombia with a DDS degree. He completed a pediatric dentistry program in Mexico. He holds a diploma in orthodontics from Brazil and a master's of dental science and a PhD in oral biology from Australia. He also holds a master's degree in craniofacial pain and sleep disorders from Tufts University in Boston. Dr. Ramirez's interests include guiding craniofacial growth and development in children. He investigates on craniofacial growth and development, the pathophysiology of functional disorders in the cranial cervicomandibular system, and how the craniofacial structures are modified by functional appliances. He has taught about his findings and extensive knowledge all over the world to thousands of doctors. And I don't know anybody that treats kids as early as Germán does. I have the honor of introducing a fellow citizen of the world and fellow South American, Dr. Germán Ramirez Yanez. Germán, you have the podium.
Thank you, Carlos. It's a pleasure to be here for everyone. Let me go to my presentation and we can start working today. So I really appreciate this invitation personally to Carlos, who is a very close friend, and also to the American Academy of Craniofacial Pain that I have been invited several times. So thank you everyone for being here. As Carlos mentioned, in my learning path, I have been in different countries trying to understand all these problems. And today I'm going to try to share a little bit of my experience with you on how I see my little patients, my young patients, and how as a dentist, I can help them not only to have a good oral health, but to have a good general health. So I'm going to try to share more than 30 years of experience in about an hour and a half. So it's going to be really hard, but I will try to do my best. This is something that I normally tell to my patients. The nose is for breathing and the mouth is for eating. This is a situation that when I say to the patients, they say, really, it's not normal to breathe through the mouth. And normally I respond to them, do you put food in your nose? Obviously, the child immediately is going to laugh and say, no, I don't do that. And I say, so why do you put air in your mouth? So mouth breathing has become like a normal situation. And the normal situation is to breathe through your nose. And that's why, for example, those of you that has been seeing patients that the patient report that they are choking very easy is because when the patient is trying to swallow and at the same time to breathe through the mouth, the airway is going to collapse to protect the airway and to permit the passage of the food into the esophagus going to the stomach. So the normal way is to breathe through the nose so we can use the mouth for eating. Another thing that you have to be aware is that if you start looking at the kids, and these kids has a beautiful face, but the lips are together all the time. So when we are with the lips apart, we are seeing that the patient is permitting the flow of the air through the mouth. So when we see a patient that we want to observe if the patient is a mouth breather, we are expecting that the patient is with the mouth open all the time. And this is what we are expecting to see. These patients are with the mouth open all the time, but when they are sleeping, but probably when they are during the daytime, not necessarily they are with the mouth open, but some of them may be with the lips apart when they are paying attention, when they are watching TV, when they are playing with a video game or something like that. And that patient is a mixed mouth breather. So they are breathing through the nose sometimes, they are breathing through the mouth sometimes, not necessarily all mouth breather is with the mouth open all the time. So be aware that when the patient is sleeping, maybe with the mouth open, but when the patient is awake, maybe with the mouth closed. But when you are evaluating the patient, you have to observe that the patient is with the lips together or it is with the lips apart. If the patient is with the lips apart, most likely the patient is a mixed mouth breather, having a partial breathing through the mouth, a partial breathing through the nose. And another thing that we have to keep in mind is that when we see these patients, these cheekbones that we are observing in this kid, that is the anterior wall of the maxillary sinus. The anterior wall of the maxillary sinus is part of the maxilla. So the maxilla is part of the airway. The lateral walls of the nose are the maxilla. So the maxilla is part of the airway. And then, as we are going to discuss later, the mandible is holding the tongue. And the tongue is running to the back down until the oropharynx. And the oropharynx is part of the airway. So when we are considering a patient in a dental office, we have to think that the maxilla and the mandibles are part of the airway. If I have a restricted maxilla and a restricted mandible, in other words, if I have a small maxilla and a small mandible, I will have a small airway and my patient can be struggling to the being in problems when it's breathing and when it's sleeping. And this baby that we are seeing here is with the mouth open. And most of the people at this age say, oh, it's very cute. We cannot do anything. We can start working with babies like this to educate the baby to breathe through the nose. Otherwise, this baby is going to become this adult 20, 30 years later with a severe sleep disorder. So there are many factors affecting this baby. It could be the position of the head at this moment. It could be the position of the body and the head that is blocking the airway. Could be a habit that the patient is learning to have when the patient is breastfeeding, when the baby is breastfeeding, because the baby is staying in a ball position, but the mom is basically holding the baby in a very horizontal position. So if you try, for example, to drink a bottle of water when you are laying down, you are going to choke immediately and you are going to try to breathe through your mouth. That may happen when the baby is breastfeeding, because if the baby is horizontal, the baby is going to try to swallow and is going to choke, and immediately is going to open the mouth trying to breathe because the baby is choking. So we may start educating the mom and working with the baby at this age to prevent that the adult or the young kid is not becoming with the sleep and breathing disorders. So when we are evaluating the way of breathing, when we are evaluating a patient that we are suspecting that has a sleep and breathing disorder, and we want to start working with breathing, we need to evaluate initially the way of breathing. Is this patient breathing 100% nasal breather, or is a mouth breathing? A mouth breather is 50% breathing through the mouth. So probably the patient is breathing through the mouth at night only and maintaining the lips together and breathing through the nose during the day. Is the patient still breathing through the mouth during the day, but partially? Because when we breathe through the nose, we are going to produce a totally different physiology in our body than when we breathe through the mouth. So I'm going to run this video. We are going to run video number 1.
Nasal versus mouth breathing.
Jordan, can you run video number 1?
Yes, sir. It's playing right now.
Okay.
Do you see it up on your screen?
I don't see it, so.
Okay. Yeah, it should be playing right now for the audience.
Breathing through the nose moves approximately 1/2 liter of air through the nose and the upper airway, whereas breathing through the mouth may move a higher amount of air through the airway. Considering that, it would be arguable to say mouth breathing would bring more air into the respiratory system and therefore more oxygen into our body. However, when we breathe through the nose, the diaphragm, a muscle at the base of the lungs, contracts and expands the rib cage, so permitting the air to fulfill the whole lungs. That is known as diaphragmatic breathing. Conversely, breathing through the mouth is performed more with the chest muscles, which only fulfill the superior 2/3 of the lungs. The later is known as chest breathing. Diaphragmatic breathing permits the air to reach the alveoli located at the base of the lungs. Those alveoli are able to distend easier, comparing with those located at the superior part of the lungs, the apex. The alveoli at the base of the lungs are capable of more oxygen exchange, as they maintain a less negative pressure, so they can be fulfilled easier, and there is a higher blood flow in that area. On the other hand, mouth breathing associates with chest breathing. Such breathing moves more air to the upper area of the lungs, with much less air reaching the base of the lungs. The alveoli, located at the superior areas of the lungs, ventilates less efficiently, and so smaller volumes of oxygen are exchanged at that region. Beside to the fact that nasal breathing moisturizes, warm, and clean the air, it is a more efficient and healthy way of breathing, as nasal breathing produces a higher oxygen exchange at the alveoli in the lungs. So reaching a higher oxygen saturation in the blood, which results in more oxygen reaching all the body tissues.
Okay, so now what happened when we are breathing through the mouth? We need to think on two things. We are doing it in the incorrect way, and normally when we breathe through the mouth, we breathe faster. So we are increasing the frequency of breathing. That means overbreathing. So either if we are breathing through the nose or the mouth, if we are a mixed mouth breather, sometimes I breathe through the nose, sometimes I breathe through the mouth, we are gonna increase the speed of breathing. So in other words, we are gonna breathe more times per minute. So we need to evaluate if the patient is breathing to the mouth and also how fast the patient is breathing. So this is going to affect all the physiology, and it's going to start affecting the physiology on the oxygen and CO2 exchange. So when we affect that physiology, we are going to affect the pH of the blood. The pH of the blood, the balance between acidity and alkalosis on the blood is very small. So basically, if we check the pH of the blood, we have a pH of 735 to 745. And that's what is permitted to change. So the more alkaline, so the more the pH of the blood moves into an alkaline situation closer to 7.45, the exchange of oxygen with the cells is going to be more difficult. So the oxygen is going to be tied to the hemoglobin. So if we are losing CO2, we are making that movement. We are switching the blood into a more alkaline situation. If we come to a more alkaline situation, our kidney is going to start releasing bicarbonates to try to compensate and to change this chemical reaction that I am not going to enter in detail on that because we don't have the time today, but many people knows that as the Bohr effect. But it's not also that the kidney is working harder producing bicarbonates. It's also that the kidney has to release minerals like the magnesium, phosphorus, calcium, and sodium into the urine to be able to produce the bicarbonates. So if we take, for example, the phosphorus, if you remember, we produce ATP, adenosine triphosphate, in our cells to produce energy. So the patient is going to start having less energy in the whole body, in every single cell in our body. And also, if we lose calcium in the urine, we are going to have less calcium available for mineralizing the bone tissues and the teeth in our body. So that way, mouth breathing can be linked with an overloading of the kidney, and that kidney is losing minerals that are going to affect directly the body energy and the body mineralization. So a problem that started as a cute child in breathing through the mouth is going to start showing us that every cell in the body is going to start receiving less oxygen. And when a cell in the body receives less oxygen, it's going to start producing the hypoxia inducible factor. This is a factor that is going to start affecting again the kidney, and the kidney is going to produce a substance that is called EPO. It's erythropoietin stimulating factor. And the erythropoietin stimulating factor is a factor that we need to produce more blood vessels. And the whole body is going to start feeling that we need to produce more blood vessels. Why? Because if we don't produce more blood vessels, we are going to start losing more oxygen. And if you think, for example, in a patient that is having a tumor, those blood vessels are going to reproduce also in that tumor. Or if the patient is developing a cancer, in the area of the cancer, the patient is going to develop more blood vessels, because those blood vessels are going to start bringing more nutrients and more oxygen to those cells. But now we are feeding, let's say, bad cells, cancer cells. So a problem that is a oral habit is starting to affect the full general health of the patient. So in kids, we know that the shape of the maxilla and the shape of the mandible are going to start affecting the airway, as we discussed earlier. And this evidence is showing us that the gold standard when a child has a problem like this, and a sleep and breathing disorder, and the child is diagnosed with obstructive sleep apnea, is to remove the tonsils and adenoids. And by removing the tonsils and adenoids is not necessary the cure for the snoring problem. And there is more evidence coming today showing that the patient is relapsing after the surgery. And most of you know Professor Guillemino. Unfortunately, we lost him last year. But Professor Guillemino was the first one connecting the dental field with the craniofacial growth and development associated with the persistence of sleep and breathing disorders. And Professor Guillemino was saying that there were many patients, and particularly kids, that deviation is in the craniofacial growth and development, that altering the functions like suction, mastication, swallowing, and nasal breathing could be associated with the problem of sleep and breathing disorders. So we dentists have a big role when we are seeing patients. It's not the idea of just correcting the tooth alignment. It's an idea of producing a change in the structure and to correct the craniofacial growth and development, and producing a change in the function to give the patient a better airway. So when we are seeing children, there are a lot of patients that they are coming to our office and they are not still a patient that could be diagnosed with an obstructive sleep apnea. So if I have a patient that is telling me my child is snoring, I should consider that patient just having symptoms that later may become a real obstructive sleep apnea patient. Or I may have an upper airway resistance syndrome in the patient. And if we see the patient and we evaluate what these words mean, upper airway, when we are talking about the upper airway, basically we are talking from the entrance of the nose, the nostrils, to the base or the bottom of the oropharynx before we go into the hypopharynx and we enter in the trachea to move the air into the lungs. So if we are talking about that area and we say resistance syndrome, it means that the syndrome, the patient is having resistance to flow the air through that way. So something could be on the nose, something could be in the nasopharynx, something could happening in the oropharynx that is creating a resistance for the airflow. So this patient may become also a obstructive sleep apnea patient in the future. So not necessarily, and you know that in a child, we are considering today less than 1 apnea hypopnea per hour to be normal. So not necessarily that patient is doing more than 1 apnea or hypopnea per hour during the night. Probably that patient is having an upper airway resistance syndrome or being a primary snorer. And we should consider those patients as a future obstructive sleep apnea patient. So as a dentist, we know that there are different factors that may play when we are diagnosing a sleep and breathing disorder. We may have obese patients. We may have patients that they are collapsing their airway. And here is where we need to evaluate very carefully and observe the frequency of breathing. How many times the patient is breathing per minute. If you remember, the normal variable is considered today about 12 breathings per minute. But we are seeing patients that they are breathing 20, 25, even 30 times per minute. The faster that you breathe, the higher the risk of collapsing the airway. So we can manage the breathing function to correct the frequency of breathing, to stop the patient to overbreathe, and in that way to reduce the risk of airway collapsibility. Or the other way that we can work is working on the structure. If we redirect the craniofacial growth and development in our patients, we can create a better shape for the maxilla and the mandible. And when we are giving a better shape to the maxilla and the mandible, we are also opening the airway. So when we want to treat a patient that is having sleep and breathing disorders, not necessarily a patient already diagnosed with obstructive sleep apnea, we need to work on the function and on the structure. We need to correct both of them. And this is a paper that I was reading this morning, and I put in the presentation just last minute because this patient was just published now in 2020 in the Journal of Clinical Sleep Medicine for the group from here in Canada. And you can see that they are confirming what Professor Guillemino told us like 5 years ago in the previous publication that I showed you, that in non-syndromic patients, for example, a short lingual frenum and malocclusions are associated with respiratory event index. So these patients, the malocclusion or the position of the tongue or the restriction on the tongue may be associated with the problem. And also that an incorrect function, tongue immaturity at swallowing, may be associated also with respiratory issues. And these patients that they did in the study are patients that they were already treated for the sleep and breathing disorder by removing the adenoids and the tonsils, and they are still persistent with the sleep and breathing disorder. So again, we are confirming that by doing the surgery is not enough, that we need to evaluate the function and we need to evaluate the structure, what malocclusion we have, because that can make the problem to be persistent and the patient to continue with the problem in the future. So, as we say before, we don't need to have an adenoid phase that we used to say in the past. We need to evaluate what's going on, Not necessarily the patient has to have the mouth open all the time and to have an open bite to be considered that is a mouth breather. We may have a patient with a deep bite. And what happens if we have a deep bite and we have a vertical problem? This space from the maxilla to the mandible is reduced in height. So the tongue has to come down. If the tongue has to come down, the tongue has to move backward. And when the tongue moves backward, it's going to close the oropharynx. So the airway is going to be closed because the tongue is entering into the oropharynx space. And also, if this distance, this height is reduced, the soft palate has to displace backward, and the soft palate is going to reduce the space in the nasopharynx. So it's not only considering that a small maxilla, because it's a narrow maxilla, is going to affect the airway, as we are going to see later, that is affecting this area of the nose. Also, a soft palate that is displacing backward or upward may reduce the space in the nasopharynx, making the breathing more difficult through the nose, or the tongue coming backward into the oropharynx, making the breathing more difficult through the nose, and the patient has to open the mouth during the night to be able to breathe. So losing the vertical dimension can increase also the sleep and breathing disorder. So when we are considering a patient and we are evaluating a patient that we are seeing for a malocclusion, we need to evaluate the breathing. If the breathing is really happening through the nose 100% of the time. If the lips are together, so the air is not going through the mouth, but through the nose. That the tongue is resting on the palate. If the tongue is coming down to the floor of the mouth, it's going to not only coming down, but also moving backward. And at that moment that the tongue moves backward, immediately it's going to block the oropharynx. And that when I am swallowing, the facial muscles are not moving, because if the facial muscles are moving, it means that the tongue is not in the correct position when I am swallowing. And that also the mastication is happening through the mouth and I am swallowing correctly, that is permitting the flow of the air to the trachea. In the meantime, the food is going into the esophagus without interfering one to the other. And if you look at this kid is 1 year old and is already mouth breather. This baby has a weird mouth that is showing that her swallowing is really bad. This child is a mouth breather. This child is a mouth breather, right? So we are seeing signs of this problem at a very early age. These kids are celebrating the first year of life and they are having problems. So if we run the video number 3, please.
The normal or physiological way of breathing is through your nose. Breathing through the nose permits to purify the air by the structures inside the nasal cavity. In that way, the air entering into your naso and oropharynx, your throat, is not going to heavily affect the lymphoid tissue in the adenoids and tonsils, which is the last barrier to catch harmful particles in the air before it reaches your lungs. Besides clearing the air from harmful particles, nasal breathing stimulates the production of gases and substances in the nose, which are going to facilitate the entrance of the air in the lungs and prevent infection in your respiratory system. Mouth breathing allows the air to pass directly into your throat, where the adenoids and tonsils are located. In that way, the air entering into your body through your mouth has not previously been purified, and the lymphoid tissue in the adenoids and tonsils become the first defensive barrier against the harmful particles contained in the air. As a consequence, that lymphoid tissue overgrows, occupying a large volume of your throat. That makes more difficult for the nasal breathing, and you make a habit of breathing through your mouth. In order to breathe through your mouth, your lower jaw has to come down, as well as your tongue has to rest on the floor of your mouth. Breathing through the nose is the correct way, and so the tongue is able to rest on your palate, stimulating a normal growth and development of your upper jaw. Conversely, when you breathe through your mouth, your tongue has to descend and protrude. At the same time, the pressure of your cheeks increases, pushing the upper jaw inwards. So the growth and development of your upper jaw is negatively affected, resulting in a narrow and high palate. The upper dental arch acquires a V shape instead of being a rounded dental arch. Therefore, your teeth do not have space to properly align. This also produces an incorrect swallowing function. Every time you swallow, between 1,600 to 2,400 times per day, the tongue positions low, staying away from your palate. That forces the tip of your tongue to position between your upper and lower front teeth. That pushes your front teeth to show out of your mouth, and your tongue resting on the floor of your mouth, with the tip of the tongue between your front teeth. That is called an open bite, as your upper and lower front teeth do not touch when you close your mouth. All those dysfunctions, mouth breathing, incorrect tongue posture, open mouth, and incorrect swallowing are going to continue affecting the growth and development of your upper and lower jaws. And as a consequence, there is less room for your teeth and they become crooked. Remember, the nose is for breathing and the mouth is for eating. Breathing through your nose and keeping your mouth closed with your lips together is going to help your upper and lower jaws to grow and develop better. But more importantly, it makes you healthier.
The problem starts very early, as I mentioned before. And one of the things that I am working with babies is in the position when breastfeeding. The baby should be as vertical as possible. So in that way, the head can be in such a position that the baby can maintain the lips together around the nipple, not permitting the mandible to drop, and then breathing through the nose instead of breathing through the nose and the mouth at the same time. And the tongue pushing against the nipple and basically flattening the nipple against the palate. So in that way, the tongue can push the maxilla and produce a good development of the maxilla. When we are producing good development of the maxilla in a baby, we are giving a better airway. When we are educating the baby to maintain the tongue up, the tongue is coming up and forward. So it's pushing the maxilla forward and is opening the airway at the nasopharynx and at the oropharynx. So in that way, we are creating a better airway from day one. That is one of the things that I recommend to the mom when I am educating how to breastfeed. And you may see that we are having more evidence now that the abdominal feeder is the ideal position. So the baby should be on mommy's tummy and in a vertical position, so not laying down, and in that way doing a correct breastfeeding. The other things that we need to evaluate early, if you remember in the paper that I showed you before, the tongue restriction is another issue. So we need to release the tongue in the babies, or even the lip frenum if the lip is not able to position correctly on the breast of the mom and the baby cannot latch correctly because there is a lip tie or a tongue tie that is mechanically blocking the correct breastfeeding. So we need to do the frenectomies as early as possible. So we do that in babies to permit a correct breastfeeding. And the other way that we work with babies is pushing the baby to the right position. So you can see here that the baby is bringing the tongue up. But if we educate the baby by pushing the mandible, we can educate the baby to maintain the lips together and to maintain the tongue on the roof of the mouth. So we can start working with babies at a very early age and correcting the tongue position and the lip seal at this age, so the baby doesn't continue breastfeeding. And why we want to work early? Because the mandible is growing very fast over the first years of life. It is not true that the best moment is when the patient is becoming a teenager at the pubertal sport. Because if we compare the amount of growth of the mandible at between 5 to 16 years old, is less than when we compare from the day of birth to 5 years old. So the mandible is growing faster over the first 5 years of life. And if we check the maxilla, it's something similar. The maxilla is always also growing faster over the first 5 years of life. So the maxilla and mandible are growing more over the 5 years of life when we have the primary dentition. So I should start treating the baby at an early age, educating to create correct oral habits, correct nasal breathing, and then guiding the craniofacial growth and development at early age to produce a good size of the maxilla and a good size of the mandible to correct the problem. So let's see if we can do that. This child is starting to get the first teeth about 6 months of age, 7 months of age. And if you see, this child was diagnosed with a Pierre-Robin-like syndrome. Why Pierre-Robin-like syndrome? Because the mandible was severely retruded, and then the tongue couldn't move. So he was diagnosed with a glossoptosis, but he didn't have the cleft palate. That is the third factor that we need, the third feature that we need to say that he is a Pierre-Robin syndrome. So we need to start working with the mandible to bring the mandible forward. At this age, I cannot put an appliance. So we train the mom to stimulate moving the mandible forward and backward as many times during the day. Then the mandible start positioning a little bit forward, and as soon as we got the first molars, we start a technique that many people know me with that technique, that is the plantar direct tracks, and we brought the mandible to our correct position, and the patient continued developing. And when the patient was becoming 6 years old, before starting changing the teeth, the patient was with a normal profile. The relationship between the maxilla and the mandible was correct. So we corrected the sagittal problem that we have when he was a baby. We corrected the vertical problem because we had a problem here that the vertical dimension was reduced. We corrected the transversal problem because you see that this maxilla was becoming narrow and with a triangular shape. Now it's a fully rounded maxilla. We corrected the coronal problem because we have both sides of the maxilla in a good shape, and you can see that now the patient have a good cheekbones, which means that he has a good maxillary sinus here to clean the air when he is breathing through the nose. So all the structural and all the functional problems were corrected at a very early age, and this patient is going to continue growing and developing with no problem in the future. So today we have papers saying that we have a big responsibility, because if we work with appliances or techniques that we use in, for example, in myofunctional orthodontics, or techniques that we use in early interceptive orthodontics, we can help these kids by moving the mandible forward. And by moving the mandible forward, we are going to give them a better airway. And as we have discussing today, if I move the mandible forward, how I'm going to give a better airway? If I move the mandible forward, immediately remember that the mandible is attached to the hyoid bone by the geniohyoid muscle and by the anterior digastric muscles. So if I move the mandible forward, the hyoid bone has to move forward. But when the hyoid bone moves forward, the tongue has to move forward and upward because the hyoid is attached to the tongue with the hyoglossus muscle. So the whole structure have to move. When all of these complex, the mandible, the hyoid bone, and the tongue move forward, the oropharynx is going to open, and I'm going to give a better airway to my patient. So let's see this patient. This patient came to the practice because the dad was concerned that she was snoring. And most of the professionals that he visited, they say that don't worry, that will be gone when she grows up. And the dad said, no, that is not going to happen because I know that I was as a snorer as a child, and now I have a lot of problems. You can see that she has a transverse problem, a vertical problem, a sagittal problem, and you can see that the maxilla is rotating to one side, so she has a frontal problem. And she has the lips together, but at night, the dad was reporting she's with the mouth open and having issues when breathing. So we did a home sleep test, and we start treating her. We start treating her with the plantar direct tracts that you can see here. And we start doing myofunctional therapy to teach her to breathe better through the nose and to regulate the overbreathing that she had. So we start treating her, and when we did the first evaluation, the first home sleep test, you can see that about 40% of the time, she was maintaining a good oxygen saturation. But the ideal oxygen saturation that should be around 98 to 100 was only around 3% of the night. So if we treat her, we see that after treating her, we gave her a 90% oxygen, ideal oxygen saturation over the night when she was wearing the appliance and even now without the appliance. So we moved from about 20% of ideal oxygen saturation during the night to a 98, 99% of the ideal oxygen saturation during the night. And if we look at the pulse rate, so how hard the heart was working, the ideal is between 100 to 125 beats per minute in a patient, but during the daytime, when the patient is sleeping, that should be reduced. And we can see that she was maintaining, the ideal for her age is 75 to 100. And she was maintaining that number of beats per minute during the night. And she was not dropping down when she was sleeping. After we did the treatment, about 50% of the time, she was reducing the heart rate without the appliance, and about 70% of the time when she was with the appliance in the mouth, she was reducing the heart rate. So what these results means that even though she was still doing some apneas or hypopneas during the night, the oxygen saturation was maintained in an ideal situation and the pulse rate was getting better. So we were getting better results. And the most important at this time is that the airway was opening. And when we are talking about opening the airway, you have to be careful because you cannot report in an X-ray that because you increase this distance or this distance on the airway, you are getting a better airway, because the airway is a three-dimensional structure. So you have, as a three-dimensional structure, you have to measure the volume of the airway. you cannot measure a distance, because a distance is just one dimension of the airway. So you cannot rely that you are giving a better airway to a patient because this distance is increasing. You have to measure the volume and to see that the volume is increasing in the nasopharynx and the oropharynx to get a better airway. So in that way, the patient was reporting that now the patient is not snoring and the patient is sleeping better. And we mentioned before that you have to be careful with the frenums, if the patient is a lip type or a tongue type. If you have a mechanical restriction, you have to correct that mechanical restriction. And if one of the restriction is the frenum, you have to do the frenectomy. And look at this paper. This paper is reporting cases that the babies died unexpected when they were sleeping. So they died for asphyxia, and they have an upper lip frenum. So they were lip tied and nobody recognized that. So they are reporting that about 85% of the cases that is a sudden infant death are associated with a lip tie. So we need to start looking closer to tongue tie and lip ties in baby. And how we are going to start doing the association. This is a problem that is starting very early. If I have a patient that is doing an incorrect breastfeeding or is having a tongue tie or a lip tie, that patient may develop mouth breathing and to start maintaining the lips unsealed. If I have this situation, that baby is going to have a tongue thrust and an incorrect swallowing later. So the functional problem is starting to be affected. If the patient is laying down, the milk can go to the eustachian tubes and the patient is going to start having frequent ear infections. And when the patient has that problem and is breathing through the mouth and not clearing the air through the nose, then the patient is going to have increased tonsils and adenoids, as we saw in the animation that I showed you before. And then a patient with tonsils and adenoids increase is going to start having a gag reflex, and then is going to move to a soft diet because he doesn't want to chew something harder because he's going to stimulate the gag reflex. So all of this is going to start deviating the craniofacial growth and development, and is going to have myofunctional disorders. So the structure and the function in this child is going to be affected. That is going to bring a chest breathing, and that chest breathing is going to reduce the oxygen in the brain and in all the cells in our body. So the patient is going to start overbreathing. Is what many people call hyperventilation, but the correct term is to say the patient is overbreathing. And that is going to lead us that the patient is developing sleep and breathing disorders and is developing a malocclusion. If nobody do anything, that is going to lead to obstructive sleep apnea and is going to lead with behavioral problems later to the patient. And that patient is going to maintain a chronic cellular hypoxia that is going to stimulate the production of hypoxia-induced factor in all the cells in the body, and also is going to maintain a chronic blood alkalosis that is going to stimulate the production of bicarbonate and EPO, erythropoietin stimulator in the kidney, and is going to overload the kidney. And then that is going to bring us to chronic degenerative disease like cardiovascular problems, diabetes, or even Alzheimer, because we are having a brain that is not receiving enough oxygen and enough nutrients. And if we are producing more blood vessels, we can facilitate the progression of cancer, or if we are overloading the heart because we are maintaining a high pulse rate over the night, we are going to end up with a heart attack. So a problem that starts with a simple situation like not recognizing a tongue or a lip tie, or not advising a correct breastfeeding, or not doing a correct breastfeeding in a baby, may end up in either a chronic degenerative disease, is facilitating the producing of cancer, or the patient dying as a heart attack. So correcting the mechanical problems and doing a correct breastfeeding is very important at the beginning of life, and we dentists have a big role on doing that. Because by doing that, we are going to maintain during the whole life of our patient this cycle. For the bones to grow, we need to work with the muscles. That's why I am talking today about myofunctional orthodontics, not just regular orthodontics. And we need to evaluate how the bones are growing in association with the activity of the muscles. When we activate the muscles, we are going to load harder the bone. When we load harder the bone, we are sending a signal to the brain to produce the correct substance that is going to stimulate muscular growth and bone growth at the same time. So if you want to give a bigger maxilla, or if you want to correct a narrow maxilla and a retruded mandible, you have to work with the muscles to produce a good size of that. And we need to remember that the maxilla grows through the intramembranous ossification and also grows through all the sutures that we have wherever the maxilla is joining another bone of the cranium. And when we are talking about the mandible is growing in the mandibular cartilage that is endochondral ossification, and also everywhere around the mandible where any muscle is attached on the mandible. So that is intramembranous ossification. And that is something that we need to keep in mind when we are treating patients, because most of the people start talking about mandibular growth and they are saying the mandibular cartilage. And most of the people are talking about maxillary growth and they are talking about the midline suture only. And we are forgetting how the maxilla grows and how the mandible grows. So we need to review all the concepts of craniofacial growth and development, because this process lasts for a long time and is an interaction between the environment and the genetics to produce a correct development, to produce a correct growth, and to maintain the system adapting in a positive way. And that is what we call today epigenetics. Today, I don't have time to elaborate on epigenetics, but if we want to give an airway, a correct airway to our patient, we need to evaluate where the airway is blocked or collapsed, because it can be collapsed on the nostrils, it can be collapsed inside the nose, it can be collapsed at the nasopharynx, or it can be collapsed at the oropharynx. So we need to evaluate where is the airway affected and correct properly. So if I am going to correct everything doing palatal expansion, I'm going to work only on one area. I'm going to work inside the nose. Yes, if I make the maxilla wider, I can give more room inside the nose, because the maxilla is the roof of the mouth, but at the same time is the floor of the nose. So, but I am working only on one area where the airway can be collapsed or restricted or blocked. So, for example, in this case, we can give a patient a better airway by producing transverse development, because this maxilla is narrow, particularly on one side. You can see, if you see this side of the maxilla is shorter to this side, and if you see the incisive papilla is pointing to one side. So that's one of the things that I call there is a frontal rotation of the maxilla, and there is a lack of transverse development. So I have two problems in this maxilla. The maxilla is rotated towards the left side, and the maxilla is too narrow, particularly on the left side of the mandible. We did palatal expansion on this patient. So what is the problem in this patient? This patient have an obstruction or a reduced space for the airway in point number 1 and point number 2. So by doing the palatal expansion, and this is a way that I do the palatal expansion, I don't use the palatal expander the traditional way here in the middle of the palate. I modify the palatal expander so I can permit the function of the tongue, because remember that I am correcting the structure, but at the same time, I have to bring a correct function, and I need the space for the tongue here in this palate. And we start correcting that problem, and we gave her a wider maxilla, but also we developed the maxilla in a sagittal direction, and we corrected the frontal rotation. You can see that the maxilla is at the center now, and in that way, we were giving a better airway to the patient, and she can continue developing easier. Then we move to the ALF appliance to continue giving the development that she needed. But now the patient is saying that she is breathing better through the nose and she is sleeping better. It's not our area, but if you compare the panoramic view here, you can see the septum deviation here. And after we give her a better maxilla, you can see now that this block area here is open now, and the nose is similar on both sides. So it's not a matter of producing just palatal expansion. It's a matter of correcting all the rotations that the maxilla may have. If we see another case, this patient has an anterior crossbite, and with the patient in this position, you can see that the mandible is sitting in front of the maxilla. Why the mandible is sitting in front of the maxilla? Because the maxilla is retruded. So if the maxilla is retruded, the maxilla is backward. So something should be happening here at the back. So if the maxilla is retruded, basically the maxilla is reducing the space of the nasopharynx because the soft palate is moving backward as well. So this is the Sassoon-Ijara back. Other people know this cephalometric technique as the Jefferson technique, but it's basically designed, initially proposed by Professor Sassoon a long time ago. So if we look the position of the maxilla in relation to this arch that you see here in red, the maxilla is retruded. If we see the position of the mandible in relation to this arch, you can see that the mandible is in the right position. So this patient has an anterior crossbite because the maxilla is retruded. And this patient is having problems because the airway is reduced at the nasopharynx. And if I check the vertical dimension, the position of the mandible in relation to the vertical arch here on red, you can see that the mandible is up. So basically the vertical dimension of this patient is reduced. So there is no space for the tongue. And if you look in detail, here is the tongue on the X-ray, and the tongue is positioning backward to be able to come downward because the tongue is sitting at the bottom. It's sitting on the floor of the mouth, not on the roof of the mouth. So this patient has a problem that the nasopharynx is reduced because the position of the maxilla, and the oropharynx is reduced because the position of the tongue. So we start evaluating him, and he have a bigger problem here on point number 3. So we need to permit this maxilla to move forward in order to open the airway here. But for this maxilla to move forward, we need to get rid of the mandible in front of the maxilla. So we start treating him with the planus directrix to give him a better vertical dimension. and we use myofunctional techniques to bring the tongue upward and to sit on the roof of the mouth and to develop this maxilla. And you can see, if I go backward a little bit, you can see that we saw the patient in May 2010, and then in August 2010, the problem was corrected. The issue was not to correct the anterior crossbite. The major issue was to give him a better airway that he can sleep better. So with this patient, we can see now that when we corrected the problem, you can see that the maxilla is becoming closer to the anterior arch, so the maxilla move forward. And if we evaluate the vertical, now the mandible is closer to the vertical arch. So we gave him a better vertical dimension, and you can see now that the tongue is going upward and not going downward as we saw before. So in that way, we are going to say that we gave this patient a better airway. And then the patient went from this situation with an anterior crossbite, becoming a teenager when the upper canines were erupting and everything is stable, and not expecting any relapse in this patient. Why? Because the structural problem was corrected where the problem was, on the maxilla, that the maxilla was retruded. The maxilla was brought forward, not trying to push the mandible backward. The vertical problem, that he has a reduced vertical dimension, was corrected and giving him a proper vertical dimension. So the structural problem was corrected and the functional problem was corrected because the tongue is now resting on the palate and he is 100% nasal breather. So in that way, you are going to give the patient a better airway and you are going to give them an stable result. So what happens when we evaluate a patient like this? Definitely in this patient, you can say that he is a mouth breather. He is with the mouth open all the time. So this is the classic patient that we see a long face with the mouth open all the time. But if we evaluate the structural problem, we can see that he has a retruded mandible. So he has a sagittal problem. You can see that the maxilla is very narrow, so he has a transversal problem. You can see that when he bites, he has a deep bite, so he has a vertical problem. And also, he has a coronal problem because if you see, the left side of his mouth is higher than the right side, so his maxilla is canted. When I am evaluating the structure of a patient, I evaluate 6 dimensions. I evaluate the sagittal, I evaluate the transversal, I evaluate the vertical, I evaluate the coronal, and I evaluate the frontal as well. That is when the maxilla is rotating to one side, as I show in the patient that I did the palatal expansion, that she had a frontal rotation. And the 6th dimension is the time that the function has been affecting the whole system. So we need to evaluate the structure and we need to evaluate the function in order to correct all the problems at the same time. It's not a matter that I have to bring the mandible forward. If you treat this patient only trying to bring the mandible forward to trying to give him a better breathing, the transverse problem and the vertical problem are going to continue causing the sleep and breathing disorder. So we need to correct all the 6 dimensions. We need to bring the mandible forward to give a better width to this maxilla. We need to increase the vertical dimension. We need to correct the cant, and we need to correct all the functions that this patient can maintain a correct nasal breathing and maintaining a correct swallowing with a correct resting of the tongue on the palate. If you see here is what I was telling you, that this side of the maxilla is higher than this side, and he has a transverse problem, a very narrow maxilla. And you can see, and this is another factor that I always check. If you envision the infraorbital point of this patient here on the soft tissues, this infraorbital point is behind a perpendicular line from the supraorbital point. In a nice profile, the supraorbital point and the infraorbital point should be in a very close relationship. In this patient, what happened? You can see that the mandible is retruded, but also the maxilla is retruded. So this patient should be treated as a bimaxillary retrusion patient. So it's not only to bring the mandible forward, the maxilla should come forward as well. So in that way, we start evaluating the patient. Here you have the Sassoon analysis as well. And you can see that the mandible is retruded and the maxilla is a little bit retruded as well. And when we evaluate the vertical, he needs to increase the vertical dimension. So what is happening with this problem? The major problem is now in the oropharynx. So if I start treating this patient just to doing palatal expansion, probably this patient is going to continue reporting having problems because the tongue is still going to the back and blocking the airway here at the oropharynx. So there is a little bit of problem here, but the major problem is because the tongue is backward, and the tongue is backward because the mandible is retruded. So I need to start working in all the problems at the same time, but not forgetting that the major blockage of the airway is here at the oropharynx. So we start correcting the patient. We use different techniques. We use several techniques with him. We use the planars direct tracks. We use a myofunctional appliance. We use myofunctional therapy. We did a little bit of transverse development with the alpha appliance. And combining all those techniques, we achieve results correcting all the problems in the 6 dimensions. And you can see that now the maxilla is developing, and now he's developing cheekbones. So the infraorbital point is becoming in a better relationship with the supraorbital point. And when we evaluate the transverse, we have a wider maxilla now. When we evaluate the vertical, we have a better vertical with this patient now. We have a better sagittal. And now the maxilla is coming closer. The mandible is becoming closer. And the vertical, he has almost ideal vertical with the mental point touching the vertical arch. So he continued developing. We continue checking the patient, checking that all the structures continue developing in the correct way and all the functions continue in the ideal way so he can maintain a correct problem. Another situation that you should consider is when the patient is grinding the teeth. A grinder today should be considered a sleep and breathing disorder. So there is evidence that is showing that these patients, when they are grinding the teeth, is that they are trying to open the airway. There is a publication, a paper by Professor Martinov that is saying that the respiratory effort is occurring just before the patient is producing the mandibular movement. So there is evidence coming to support the idea that when you have a grinder is because the patient is trying to open the airway. So be careful with that as well. So to correct and help the patients with those health issues, we can help as a dentist by reestablishing a correct craniofacial growth and development. And that's what I call craniogenesis. And we can stimulate craniogenesis to change the structure at any age. Obviously, the earlier that we can do the problems, we can correct all the problems, the better for the patient, because in that way we are going to bring the baby or the child to a normal physiological situation, and it's going to continue correcting earlier. And you can see, this is a report that came recently, and you can see that the bones continue responding to the loading of the muscles. And if you see these cases are in a report that the occipital bone is creating atosis, is creating like a spike of bone in those people that they are holding the head back, head forward now, working with the cell phone all the time. So they are finding that in adults, these ligaments and muscles of the neck are overloading the occipital bone, and at the insertion of the occipital, those muscles of the neck on the occipital bone, the bone is producing an exostosis and producing like a spike in adults. So bone growth can occur at any age. So we can produce big changes. For example, in this patient that we have a malocclusion, and immediately you may recognize that she has a posterior crossbite. And you are going to say, all right, I need to correct a posterior crossbite. I am going to do palatal expansion. Is that enough? Is going to be stable? Are you seeing the other problems? Yes, you are seeing the big one, a posterior crossbite. But that is a coronal problem. This maxilla is rotating in this direction. But what about the transversal? She has a narrow maxilla. What about the vertical? She has a deep bite, and that's why the lateral incisors have to go at the back. And she is a mouth breather during the night. So if I don't see the functional part, I'm going to be in problem as well. We start treating her in March 2014, and you can see in May, we gave her a better vertical. And now we are working with nasal breathing, and now that she is breathing through the nose, we are working for the tongue to stay on the roof of the mouth. So we are doing myofunctional therapy to help us to correct the problem. And then we start seeing that the transverse problem was improving, the sagittal problem was improving, the vertical problem was improving, and the teeth start aligning with no problem. And less than a year later, we can see that all the problems have been corrected. So we continue checking this patient, that all the structure continue developing correctly, that all the craniofacial growth and development continues in the correct way, and all the functions are maintained in the correct way. So we went from this situation in March 2014 to this situation in January 2015. And then the patient continued developing with no problem. 1 year later, she is developing with no problem. She continued doing well, and she is sleeping very good. She's a nasal breather. She continued developing on the over the time. From 2016 to 2018, we don't see any change, and she continued doing okay. And everything is maintained. I have seen her 1 year later, and everything is maintained okay. So when you understand the function of the mouth, you can start producing big change and even making bone grow where you don't expect. This is a baby that we saw some years ago, and you can see that she was deviating the mandible to one side. And if we look at the x-ray when she was 3 years old, you can see that here on the right side you have a condyle and a good TMJ. but on the left side, she doesn't have a condyle, she doesn't have the mandibular fossa. And then she continued deviating. They put a rib here, trying to stimulate the formation of the mandibular condyle. They didn't get any result, and the patient continued developing and not TMJ developing here 2 years after the surgery. So we start treating her with a functional approach with myofunctional orthodontics, and you can see that now she's developing the condyle and the asymmetry of the face is corrected. We corrected that, understanding how is the dynamics of the mandible when we are doing a correct mastication. And with functional appliances that were designed to stimulate the mandible to move to the right side and blocking any movement to the left side. By stimulating the mandible to move to the right side, we were stimulating the TMJ development on the left side. So when you understand the dynamics and the biology of the mouth, you can produce these results, and you can see that the condyle is developing, and she's developing a normal TMJ on the left side where she didn't have a condyle. And you can see that it was not the effect of the rib that they put during the surgery, because the rib is out here, and actually the body is trying to push the rib out of the TMJ because it's not doing anything there. So the body is going to try to remove that. And we did a follow-up over 5 years, and you can see here that the patient has the rib, the body is trying to push out the rib, and she has like this bulk here on her face. And 5 years later, that has been resolved by the body, and the rib is gone, partially gone here, but it's not causing that bump on the face of the patient. And when we follow with another CT scan, you can see that the TMJ has fully developed here with no problem, with similar condyles on both sides. And you can see here that the rib is almost resolved here, and there is a little piece of rib here, but the body is removing that. So we can produce this effect if we correct the function. Another case of anterior crossbite, I'm going to run fast on this case because I want to show you the final 2 cases that may be more interested for you regarding to TMJ and sleep and breathing disorders. And you can see that in this child, we start correcting an anterior crossbite at a very early age. Then we continue following the patient, maintaining a good development, correcting problems. And we were seeing problems in the entrance of these canines. So we will have to develop a little bit more later with the alpha appliance. So we continue working with that patient and following all the time, guiding his craniofacial growth and development and his functions in the correct way, giving the correct space for the teeth for they coming in the future. And then we continue, and now the canines are coming in the mouth with no problem, and this patient doesn't need further treatment. And everything coming in a good relationship, and the patient continue growing with no problem. This is a case that I want to share with you. And this case came to me because the patient was with craniofacial pain and having problems to sleep. And if you see, she didn't have a big structural problem because she had fixed orthodontics before. But when you check, all the teeth are aligned, but you can see that there is an increase over jet, and this patient was having a tongue thrust every time that she was swallowing. So we start working with her. I'm gonna try to run here something directly from YouTube. Let's see if that works. Yes, it is working. I want to confirm that you are seeing.
We cannot see it, sir. No, sir.
You cannot see. All right. So it's not working. as I wanted. So are you still seeing my presentation?
Yes, sir.
Okay. So it's not working. So I'm going to go back to my presentation. So I'm going to run the video here when she was opening. I know that you are not hearing, but when I am palpating the TMJ and she was doing the opening, she was producing a strong noise in the TMJ. So we start treating her, and every time that she was swallowing, she was saying that was the trigger of the craniofacial pain, and immediately she was trying to choose something. She had a lot of noise in the TMJ. So we start treating her, and we reduced the tongue thrust. So we went from this situation to this situation by correcting the tongue thrust and by correcting the swallowing. So by correcting the functional problem, all the noise in the TMJ was gone and the craniofacial pain was gone, and the patient said that now she was sleeping better and resting better. And I want to share you this case because many of you are going to say, oh, yes, you are doing that in kids because the kids are growing. This is the oldest baby that I have treated an anterior crossbite. He is a 70 years old baby. And you can see that he has an anterior crossbite as the child that I show you that he was 4 years old correcting the anterior crossbite. And I treated him exactly in the same way. When I saw him, I saw a sagittal problem because the maxilla was retruded, a vertical problem because he has a deep bite, a transversal problem, and he had a lot of very bad restorations in his mouth. So we start treating him in the same way, working with increasing the vertical dimension, and he continued developing at this age, continue developing the maxilla and the mandible, bringing everything to a correct position. And you can see that by changing the position of the maxilla and the mandible, we got an open bite at some point because the maxilla had a cant, and then that kind start improving, and then we corrected the coronal problem. So this side of the maxilla that was up start coming down and leveling the maxilla and correcting the cant. So we corrected the sagittal problem because the maxilla moved forward. We corrected the mandible position in the vertical, so we gave him a vertical dimension that is correct. We corrected the coronal problem because we corrected the cant, and now the patient can be restored in that position. But the most important part is not that we corrected the anterior crossbite. The most important part is that the patient was waking up choking when he was in this position, and now he's saying that he is sleeping very well, that he is not choking at night, that he is feeling very well and resting very well at night. So we move this 70 years old baby and we re-establish a good sagittal, a good vertical, a good transversal, a good coronal, and a good function at breathing and swallowing at this age as we do with children. So the age is not the limit. You can give a better airway by establishing a better airway, as you can see here in the CT scan, that the volume of the airway has improved at the nasopharynx and at the oropharynx by giving him a better structural and a very functional. So if you want to learn more and have more information, I invite you to come to my website, kidsmalocclusions.com. If you register in kidsmalocclusions.com, you can see a lot of material that we have. Now we have video conferences that I gave over the last weeks. You are going to have all my articles that I have published on this. You can read my book about early treatment of malocclusion. You can see when I am giving a course. We are having a full day conference over the following weeks that you can get the information here, or you can contact us if you need more information. So if you want to register in kidsmalocclusions.com, you will have access to all the information that I have produced. The animations that I show you today, they are available in this website as well, and they are available in YouTube. But here in the website, you have other material that we have produced more than those animations. So please come to visit my website, and you will be happy with all the material that we are sharing there. So thank you very much for your attention. I hope that you found this information useful, and I'm gonna stop sharing my screen now, so we can go back to the main screen. I think that we have some time for answering questions that you may have.
Thank you, Germán.
Yes,
That
thank
was
you so
another
much, Dr.
wonderful
Ramirez.
presentation.
Go ahead, Dr.
Go
Bise.
ahead. Okay, well, thank you, Germán. That was another wonderful presentation. You have a wonderful way of explaining things. I guess we can call you the master guider. You do a beautiful job guiding growth and using the patient's own resources with a little help with functional appliances to make things work in such a simple way that it's amazing. Love hearing your videos on those cases. Very interesting cases. We do have a few questions that, if it's okay, Jordan, we can start going to some of the questions, please.
Yeah, I can go ahead and read them off if that works
Okay.
for you.
Jordan, if I open the chat, can I see the questions here? Or?
Sure.
Yes, you can. Yes, sir.
One of the first questions that they asked, I'm going to try to go to the very first one that we had. They want to know about genetic predisposition in these cases. How much of this is genetic predisposition?
Okay. I suppose that when we are talking about genetic predisposition, they are talking about anterior crossbite. And actually, there are some publications, but I may quote a book that was published recently that is about the orthodontic treatment of class 3. And in that book, they say that even though they may be a genetic predisposition, let's say that the dad and the mom has an anterior crossbite. So we may say that the child may have a genetic predisposition. The environment play a high role on expressing that anterior crossbite. That's why today I did of buying that fight that this is genetics, this is functional. That's why today I base all these concepts in epigenetics. Epigenetics means that the function is telling the cell how to do the genetic expression. So even though the patient may have, for the sake of the argument, let's say that we may accept that there is a genetic predisposition. If we correct the function, we are going to change the environment. And if we change the environment, we are going to change the genetic expression of the cells. So we are not going to permit that genetic to express in the wrong way. We are going to permit the genetics to express in the physiological way. And another thing that I don't accept that is a genetics per se is that if we are talking that there is a genetic problem, we have to say what gene we are talking about. And so far that I know, nobody can mention a gene for a distal occlusion. Nobody can mention a gene for a mesial occlusion. Nobody can mention a gene for a narrow palate. Nobody can mention a gene for a coronal rotation, a cant. So we cannot say that there is a genetic problem.
Yeah.
The problem is how the genes are expressing. And what is giving the information for the gene to express is the environment, the function. So that's why through the function, I can change the genetic expression, how the cell is reacting to the new environment that I am creating.
Awesome. They're also asking here, can a deviated nasal septum due to trauma or any other cause, will that affect the myofunctional balance? I think you show a case actually where you corrected the septum by doing treatment without touching the nose, I believe, right?
Exactly. In that patient that I did part of the treatment, I did a palatal expansion, and I corrected the position of the tongue. At the end, we saw the deviated septum corrected. And if you think, what is the septum? What we are seeing on that panoramic that is showing the septum. The septum is the nasal bone with the vomer bone, with the cartilage, the nasal cartilage, sitting on top of the maxilla. So if I move the maxilla in this direction, the septum has to crook. If I move the maxilla in this direction, the septum has more room. So I am not an ENT. I am not going to offer the patient that I am going to correct a deviated septum as a dentist. That is not my field. That is not my role. But in this case, I just call the mom and say, hey, look at here, what we are seeing here. With the treatment that we did in the mouth, the nose is opening, and now you can see that both sides of the nose are symmetric, right?
Mm-hmm. Yep.
And it is a consequence of the treatment. But as a dentist, I am working in the mouth. I'm not going to offer something that is not in my field. Right.
Somebody asked a question about a canted maxilla, usually associated with canted base of the skull. And somebody also replied about using the ALF to correct that, which I know you use on your cases. So can you tell us a little bit more about that?
Yeah, one of the things that I associate the cant, that is what I call a coronal rotation, right? It's on the coronal plane. If you think that this is the maxilla, and my maxilla is rotating in this direction, what is happening on the rest of the cranium? So this side of the maxilla is going up. The maxilla is attached to the zygomatic bone here. So this zygomatic bone has to become shorter. The zygomatic bone is shorter and upward. The zygomatic bone is attached to the temporal bone. So this temporal bone has to move in this direction. The temporal bone is attached to the parietal bone. So this has to rotate in this direction. So this parietal bone has to rotate in this direction. So I am rotating my face in this direction. Why the maxilla is rotating in this direction? It may be due to many factors. A baby is sleeping only on one side with a pillow here, pushing the maxilla upward. A child chewing only on one side, loading the maxilla in this direction. A trauma here at some point that is pushing this temporal bone and parietal bone here, so the zygomatic and the maxilla have to follow. There are many factors. Yes, when I am correcting this, I need to give support to the maxilla, and I need to correct the structural part that could be with the appliances. In most of the cases, I use the ALF appliance to give that support to the maxilla, but I need to also to change the function. If my patient is chewing only on this side, I have to make the patient to chew on the other side to create the opposite loading. If my patient is sleeping only on one side of the face, I have to educate the patient how to sleep, to overload in a different way. So that's why I have to correct all the problems in the structural that involve 5 dimensions plus the 6th dimension that is the functional part.
Mm-hmm. Awesome, great. Somebody asked a question here about what tell us about the system you use for myofunctional therapy and what devices you prefer. I know you have many devices, and you mentioned your course, so I guess they can learn more about it, but maybe they want to get a little bit of an idea, general idea. You mentioned planostrikes, you mentioned expanders, you mentioned alpha appliances. Anything else that I haven't mentioned?
Yeah, I use many techniques, and I combine, and the most important part is that you are using whatever technique or whatever appliance for that the technique was developed for. During my mini residency that we are trying now to put together, because it was supposed to start next week here in Toronto, and now we have to move everything digital. On May 16, I am giving a full day conference that I'm going to elaborate a little bit more on that. And then we are going to move to have the mini residency online in some cases, and we are going to keep still the presence one here in Toronto starting later. But in the mini residency, I train you to use the Planner's Direct Tracks. That the Planner's Direct Tracks is intending to accommodate the mandible in a correct position to the maxilla. We use different myofunctional appliances. It's not only one brand. We use different myofunctional appliances that you have many in the market that you can have. I use the ALF a lot. I use the palatal expander that I modify. I use intraoral maxillary retractor that I modify. And I teach you all of that in the mini residency. And also we train you in the myofunctional techniques that we use. We use myofunctional therapy to correct the nasal breathing. We use myofunctional therapy to correct the position of the tongue. We use myofunctional therapy to correct the position of the tongue in the mouth to produce a correct swallowing. We increase the activity orbicularis oris to maintain a correct lip seal. We work on the body posture related with the head posture with myofunctional therapy as well. So we have different protocols that we apply at different stages of the treatment of myofunctional therapy, and that is also a full course. We are developing a full app. I have an app that is called Kids Breathe Well that you can access in my website. You can get the information, or you can get on the Apple Store and the Windows Store for any device that you can have, that we use to regulate the overbreathing in the patient. When we have overbreathing, we have many tools that we have developed our own, and that I will share with you if you come to my mini residence, how to use them, and to train you on all the protocols that we use for myofunctional therapy and all the appliances that I use for correcting all the structural problems as well. Having said that, also you need to understand how to evaluate your patients considering the 6 dimensions. Because if you evaluate your patient only on an X-ray, considering only 1 or 2 dimensions, you are going to produce partial results and you are going to fail. So you need to evaluate the patients in 6 dimensions. And in that way, the only way that I can have time to train you is by coming to the full mini residency.
That's going to be my takeaway today, though, those 6 dimensions, including the time. The time is very critical, doing it at the right moment, at the right time.
Exactly.
That was another great presentation. I understand some people have problems with the connection, so please do go and watch the YouTube channel recording that we'll have of this. I know on my end things work very smooth, so sometimes the problems could have been on your end with the quality of internet sometimes. So when you watch the recorded version that we will have there, it should be pretty smooth. I don't think we have any more questions for today. Do you have any other things to mention?
So thank you very much for inviting me, Carlos, and to the Academy of Craniofacial Pain for inviting me to do this webinar. For those that probably lost part of the conference or want to share, Also, we are going to coordinate that in my website, in kidsmalocclusions.com. I'm going to have the link for your YouTube channel. So in that way, they can access also this. So we are going to work over the following days with you to make that happening. So it's going to be available on both sides. And thank you very much for letting me sharing with you guys. And I hope that you enjoy and all your participants have enjoyed your time this afternoon.
Yes, thank you, Dr. Ramirez and Dr. Vise for being part of this. And yep, to all attendees, you'll be receiving a webinar recording as well as an email with a survey for CE credit. And other than that, thank you, gentlemen, and enjoy the rest of your day.
Bye-bye. We'll see you guys. Have a good day. Stay safe. Bye-bye.
Thank you.